Oh, this is the podcast studios brought to you by Machine Inc. Welcome, everybody. Good afternoon, Brian.
Gano, good afternoon. Great to be here.
Good to have you. So, we went for a little walk. That was nice. And I didn't know, but I do now that you're specifically trained, for lack of a better word, in infectious diseases.
That's right.
And you are an MD?
I'm an MD. Yep.
How long you been an MD?
So I finished medical school in '07. So approaching 20 years now, I guess. Yeah.
Yeah, 3 years away or two years away.
Yeah. So once you finish the med school, you get that degree. You're an MD since then. There's still more training to go on, but yeah. So 18 years.
18 years. So you've seen a lot in 18 years.
Yeah.
Where did you, out of school, where did you start to, how did you get up to where you are? What did you go through?
Yeah. So the training, starts really after high school, which is different from other countries. A lot of times it's kind of built in. Once you start high school, college, it's all one big track. So, but in high school, we finish that up and then you get to go to college, and then people always shift their majors, which is actually what I did. I went to University of Illinois and went there as a business major.
Really?
Yeah. I didn't really know what I wanted to do. I was good with math and I liked numbers, and I also like science. So I went as a business major.
You didn't know what you wanted to do and became a doctor?
Yeah.
That's cool. That's really cool. All right. So you started in business.
Yeah. So it took me all of one semester to realize that that was not what I wanted to do.
Mm.
I went to a couple econ classes and I was like, oh, this is terrible. I'm going to be in a cubicle crunching numbers without talking to people,
Yeah.
interacting, building relationships. Not that that's not a good job, but that wasn't for me.
Yeah.
And so it literally took me one semester, and I went back in and talked to my advisor at school, and I said, I'm not going to do business. I'm going to go into the sciences and do pre-med. So even though I didn't know what I wanted to do, it kind of was like, oh, I didn't want to do this.
Yeah.
What are my skill sets? What do I like to do? And so I liked science. I liked being around people. I liked building relationships. I liked helping. And so I was like, well, being a doctor. And I think a big influence was my parents. They were both, I was the first doctor in the family other than some doctors of pharmacy. So I had some cousins that became pharmacists. But the first medical doctor, I was really the first one to try it and become a doctor. So, but my mom's a nurse and my dad was a surgical technician. So kind of like the surgical nurse or assistant that helps the surgeon with all the instruments and all that stuff. And they both were in healthcare. So I think really it had a big influence on me subconsciously. I don't think I really realized it until I'm in college sitting there saying, what am I going to do?
So, yeah.
And my advisor said, this is crazy because everybody goes into pre-med. It's really difficult. They don't think they can get through the organic chemistry, or this is really not what they want. And they want to go into business. And so she's like, you're the first one that's kind of come the other way saying, I want to leave business and do pre-med. So that was pretty funny.
Yeah. So after you got that situated, out of school, was it easy to get work? Did you know what you wanted to do? How did you get
So
deciding to be a doctor?
The process there. Yeah. So luckily I did well in school, really worked hard and got through all my pre-med requisites. And then you take this big test called the MCAT. I don't know if you've heard of the MCAT before.
I've heard of it, yes.
It's pretty much the medical school entrance exam, and it's rough because you put all this time in, you put all your college tuition in, and then if you get a really bad score on that, you can take it more than once, but if you really don't get a good score, it's pretty much very, very difficult, if not impossible, to get into med school. So I did well on that and was able to, apply and had interviews at a lot of places, but that doesn't, guarantee it either. So I was about to graduate from U of I and still hadn't really been accepted formally into a medical school. So I was on a couple of waiting lists and just kept calling them, and because they kind of offer more spots than are available because they want to fill it, and people obviously choose other places. So the,
Are there more qualified? Is there a lack of people, or is there like a good balance? Like, do they have a lot of candidates coming in that are qualified, or is it like,
I
are
think
they looking and it's hard to
yeah,
find qualified?
no, I think there's plenty of qualified. I think there's actually more applicants than there are spots available. Yeah, and I don't know how, because going all the way back then, I'm not sure what the scenario is now, but I think it's actually even more difficult. I think there's even more qualified applicants now than there was when I went to apply. So you do. So once you get into medical school,
How'd you do on your test? That's the most
oh,
important thing.
I did well. I thought, well, I did training, I did the pre-tests and all that kind of stuff.
Yeah.
But I was like, oh, you know what? I could do better than this. This score is, it's good. It's going to work. It's not a clincher that I'm going to get a med school. I'll take it again. I took it again, got the exact same score. So I said, well, this is my score, and this is what we're rolling with. So
Do you know? Someone asked me this recently, or I was talking with them. If you take it twice, do they know you took it twice?
they do know. I don't know if they know your first score. They probably do. They seem to know everything, but they do know you took it twice. I do know that.
I go to the doc. They always know it. You know what's wrong with me and how to fix. No, I'm just kidding. So okay, so then
So then medical school
yeah,
is 4 years. So it's usually standard is kind of 2 years of more book work, but this book work is really directed at physiology, how the body works, pharmacology, so all the medicines, their side effects, their function, um, um, patient care, right? Like how are you really supposed to go into the room? How are you supposed to examine somebody? The
hmm
art of the physical exam and teaching what certain maneuvers mean or what they can help you diagnose. So that's a lot of the first 2 years with a little bit of sprinkling in of clinical medicine, right? You might shadow a mentor, you might do some rotations, or you might work in the local clinics and you're exposed. But then the last 2 years are pretty much 100%, patient care hands on. So, and they're resident rotations, or excuse me, student rotations. So the last 2 years, pretty much every, 6 to 12 weeks, you rotate between, let's say, internal medicine, and then you do psychiatry, and then you do surgery. And so you kind of rotate through all of them, all of third year.
So
And
psychiatry, all those are all like prerequisites to graduate. So any doctor is going to have experience in those things
correct.
because
Yeah.
they're necessary. I'm sure
Yeah.
the psychology, right? How you approach. Well, I don't want to complain about any. Maybe when we're done, I'm gonna ask you some questions. Um, so how did you like it? I mean, because going from books to people it's totally different.
Yeah. Yeah. I think that's, for me, that's what I love the most, about my job is people, is meeting the people. So for me, when I went in, everybody in pre-med is pretty darn smart. And then once you get into med school, everybody's really smart. And
Yeah,
so you're always used to being at the top of your class. And then I did fine. I wasn't, doing bad, but I was like, there's so many brilliant people. And so I was in the class doing fine, but there's so many people that are just like top of the class.
yeah.
And it was kind of different that ways. But I never felt like I struggled or I wasn't where I was supposed to be. Um, but then when you jump into the patient care, that's where I felt like I excelled. Like
That's what's most important,
this is
I
what I
think,
like.
because being an adult, I'd like to consider myself an adult. Like, like the mental fortitude is something that it doesn't matter how smart you are, how brilliant you are. Like you don't know how you're gonna handle that. Like how did that play a role? Like from people that seemed like brilliant were doing great, but then you actually put them into situations involving people, involving stress, involving, just things that are a part of statistics of being a doctor. That like how do you handle that? That's like in my opinion, that's like got to be a really difficult part because like it's already so hard to get there, but then that's something that's like you're a people person, so I know you said you excelled there, but did you notice it hard for people? Did you find it hard? Did you have to like cope with certain things, or was it just easy for you?
Yeah. Hmm. Good question.
Thank you. Did you see people fall off the rails?
I think what's interesting to me is it seems like there's certain personality types as a generalization, not
Yeah.
as the rule, that kind of tend to go to different fields.
Okay.
So I think I really didn't see people fall off the rails, to be honest, in terms of that care. I saw people realize kind of early on. So I saw people first and second year medical school that this is too hard. This is not what I'm going to do. Or they had enough experience
Hmm.
where they said, I can't handle this. And so there's some people that just decided not to pursue,
Yeah.
Um, I can't really recall like a big, really off the rails breakdown, can't do it. I've seen people that like were maybe the more brilliant side of the book medicine. And then it's like, you can't even explain to the patient like the basic thing, or you don't perceive, you can't read the room,
Yeah.
right? You can't read the room and kind of see what they're really worried about.
Right.
Not that they weren't trying their best, but so I've seen that. But I do think that as a generalization, which isn't always the best thing to do, but certain personalities might go into surgery and certain personalities might go into psychiatry and certain personalities, go into ER, right? So kind of like, or anesthesia, kind of people that like to work with their hands, right? They're going to do something like that. Or people who are more extreme adrenaline seekers are going to do more, like emergency room stuff. So it's kind of interesting, I think, that the different personalities, not as a rule, but you can kind of see that. I think
They find their niche.
yeah.
They
So you
make
can
their way in and
yes,
where they fit. Well, obviously they're pretty intelligent people. They have the wherewithal, so they are aware of themselves and their tendencies, right?
yeah.
Fall into those categories. And you, people person,
So I like to think so. Yeah.
I'd like to think. Did you get it? So after the 4 years,
So
where
yeah.
did you
So
go?
then, as you're finishing medical school, you take a few more board exams. They call them step 1 and step 2, and similar to the MCAT, is if you get a really good step 1 score and then you have to back it up with a at least an average or a good step 2 score,
Hmm.
then you choose what type of specialty you would like to go into.
Yeah.
And those also can be based on your score. So sometimes either the highest paying jobs or the best lifestyle jobs or the most interesting jobs then become the most competitive. So you have to have a step 1 score. So if you're average on your step 1 score, you might actually not be able, or very hard for
Yeah.
you to enter into a very difficult specialty like plastic surgery because it pays so well and it's on TV and people like to say, oh, I want to do that. Um, Dermatology, they got a pretty good Monday through Friday schedule and very good you know compensation. So you really have to get pretty big scores to get into some of those different specialties. So
Really?
sometimes what you end up electing to do
Hmm.
is based a little bit on that, but it's not the only thing because you can then do rotations in plastic surgery or dermatology or orthopedics, and if you have you do good, you get good letters of recommendation. Those carry a lot of weight, so it's not just a score. So you can do anything you want, but that score does affect it. So once you finish, you apply. So based on your scores and your letters of recommendation and how you've done over the 4 years, you apply to different programs across the country of what you want to do. So if it's pediatrics or internal medicine,
Hmm.
you apply and they look at all the candidates, and then they have a certain amount of spots each year at each institution.
Okay.
So then they offer you an interview, right? And so then you go interview, and that was kind of fun because you're just, for me, I took the point of view of like, oh, am I worthy to get in here? So no, it's like I get the decision here, right? Like, do they want, do I want them, not do they want me? And so that was kind of a little bit of a turnaround
Where was
for
a
me.
few? Were they all in your specific field, or would they have lend you to different like specialties?
Yeah,
Or
so usually you just have to choose one field or a combo might sometimes people might not be sure. So maybe they're trying for the big one, but their scores might be questionable. So they might kind of apply for orthopedic surgery, but they might also apply for general surgery just in case, like they can't get into. But generally, you pick one, and that's what you interview with, and that's kind of what you go
what
with.
did you pick? What was yours?
So I like everything, so I couldn't pick. So I picked two. I picked MedPeds, which is actually a combo program.
Okay. What's
So
med?
it's a you do both. So I did internal medicine and pediatrics. So it's a little bit longer, but then you do two
Hmm.
things at once. So most people pick one. I pick two.
So med peds and peds is two.
So So internal medicine is one specialty, and pediatrics is another specialty.
Sorry, I had a
Eh,
thought for a second.
But then there's certain programs across the country that will train you in both, and so and that's what I ended up applying to
So you went for two.
for two specialties. Yeah,
Is that
so it was
rare?
not common. I won't say rare because rare means like,
Yeah.
but yeah, it's uncommon for people to do two.
And they're able to actually give you work in both fields, like
Yeah. So every 3 months we'd flop. We do, and each program's a little different. Sometimes they would do 6 months, or we would do 3 months of pediatrics, then 3 months of medicine, which is mostly adult, right? And then 3 months of peds. So we would do 3 and 3 and 3 and 3 and alternate over 4 years.
how is
And then we had to take a board exam in pediatrics and a board
okay.
exam in internal medicine.
So after you're a doctor and after you're hired, you take board exams?
Yeah.
How is everything not internal medicine? Right? I mean, if you're doing
Well, as the pediatricians say, that kids are not just little adults. So the physiology is a little different, right? So mostly everything is internal medicine if you look at it at that point, right? Like that's the base for everything.
yeah.
Um, so the diseases, the medicines, and everything. But in internal medicine training per se, you don't get trained to suture people, to operate on people, to really
What's
get to the
suture? What's suture people?
stitch people up.
That's
So
okay.
things, yeah. I guess you do learn a little bit of that in internal medicine, but I'm saying like, big surgeries and colonoscopy, like those things are so specialized that you need focused training. So at the base of it, everything probably is internal medicine if you look at it from that viewpoint. Yeah.
When you're doing just internal medicine, like learning it, what are you focusing on then? If it's not sutures, you're not sewing
Yeah.
people up, what is the
Well,
focus
it's
roughly?
probably what people would think of going to their doctor, whether it be in the hospital because you're sick and the
Mhm.
doctor taking care of you each day, or going to the clinic to see your doctor. So we're trying to know as much as we can about everything, right? So trying to be a jack of all trades, I would say.
Yeah.
So learning about, yeah, all the different diseases, most common stuff, how to treat it appropriately, but then all the rare stuff. So that if something comes up that people can't figure out, you try to
Well, that's important to
investigate.
you because if you like all people, that keeps you with the ability to be more diverse in the practice, right?
Yeah.
Than just, well, that's kind of a way for you to stay open to different opportunities or just a future.
Yeah.
That was kind
I
of,
would say so. Yeah, I think as we talk about this, I think these are kind of like even making that decision, because some people say, well, when did you want to become a doctor? And I said, well, it happened first year of college, but there was no one specific moment that said, oh, I'm going to be this, a doctor. And then there was no specific moment like, oh, since 10, I wanted to be a doctor.
yeah.
And so, I mean, it's always good to talk about things. I'm not I wish I had more time to reflect and think about the why of stuff. But
Yeah.
even just these conversations, it's kind of interesting to think maybe because I do like interacting with people, and that's a favorite part of my job. That's why I did med ped, so I could see kids, I could see adults. Maybe I did general practice because then that opens the doors to all these things. So
Yeah. So you got into med peds and internal medicine right out of school, and how long you doing that?
that was another 4 years of training. So we
So it's
had our
still
4 years of college,
hmm
4 years of med school,
hmm
4 years of med peds training, which is actually accelerated. So if I just did pediatrics, it would have been 3 years.
okay.
If I just would have done internal medicine, it would have been 3 years.
Okay.
And so if you had 3 and 3, that should be 6 years,
Right.
but they condense it into 4. So
So you get a lot
a
of
lot,
experience.
a lot in 4 years.
Is
Yeah.
it more time physically in actual like
That's a good question. I don't know if it's physically more time, but it is. I think there's a little bit more expectations. I mean, we do a lot of ICU training where other people might, have 3 or 4 months of ICU. We do, 10 months of ICU. So like it's a little more intense, I think.
well this might be off the track, but how long before you find yourself in a situation with like just mortality? Like people are death is like a part of is it always a part of being a doctor that it's just like accepted like hey this is just
Yeah.
par for the course right out of med school or even
Yeah,
in med
in med
school?
school. In med school. I think even at the beginning, right? Those first 2 years when you're in the books,
Yeah.
you still have these clinical experiences and you might not know what it's going to be, right? It could just be if your mentor's an ER doctor and you go shadow and work an ER shift with them, like you might see it your very first clinical experience in med school,
Oh no, okay.
right? Or if you're working with an oncologist, cancer doctor, you
Yep.
might be in clinic with somebody who has, newly diagnosed with cancer, right? Like you go into the room and your doctor that's, mentoring you is telling a patient for the first time that they have cancer. So I think it's definitely a part of it. Yeah. From the start, from the start.
So being in internal medicine and with pediatrics, so right away you're exposed to like really sick children.
Yeah.
How was that? Like, I mean, I have kids and I'm sick and they're perfectly fine.
um, yeah, I think a little bit of that is with it, now being a parent, obviously with two kids,
Yeah.
it's different. And I had friends that were like, when we were doing our training, they were parents already, right? They were married. I wasn't married during my my residency training. I got engaged and got married right at the end of it, but I didn't have kids. So I think that's a big difference. First
Yeah.
of all, right? I think if I was doing pediatric training as a parent, it probably would have been a little bit different in terms of my perspective.
Think it would have been harder or easier or
I,
looking back
I think it would have been
different?
easier to give advice because I kind of experience it and can kind of um, empathize with
The-
having the newborn or the kid that doesn't stop crying, or they're sick, and you just feel so worried about it. So um, but then at the other flip side of that coin is that I was more objective, right? I can tell them what I'm seeing, and then you
Mm.
don't have that playing a role.
Yeah.
I think seeing sick kids was, for me, I don't know why I was able to handle it. I think, when you said, in personality wise, there's other people that really said, I can't see sick kids.
Yeah.
I can't watch. I am not doing pediatrics because that would be the worst thing.
Yeah.
And so I think, people didn't go off the rails per se, but people were like, man, this is terrible.
Yeah.
And I even have friends now who are parents who are like, how can you do it? Like, how do you see sick kids? How do you see kids with leukemia, lymphoma that go through bone marrow transplants or chemo, or, baby that has a fever, they need to do a lumbar puncture. Like, how do you do it? Like, I can't even imagine it once, and you do it every week.
Yeah.
And so,
You must
yeah,
be good at it. You must you must be good at it. You must have a good success rate. And I mean, no, because to a large extent you're kind of the hero in this situation, right? Because you're a very calm person, and if you're calm and confident and you have that sort of energy around kids, whether let's say they're in a terminal situation or not, it probably brings a lot of comfort and reassurance, for any amount of time. And I think you do have to be a certain type of person. And I mean, obviously, it goes without saying you must be that type of person because that's what you made it through it. Have like easy way to talk about it. Um, yeah, no, that's something I wondered. Um,
I think it's hard to explain, because even when my friend asked me that, I'm like, I don't know, because we're kind of conditioned a little. I won't say a little, but I mean, I think because you see it so much, right? Unfortunately, it's not that it doesn't affect me, and it's not that I put it in this little box and put it in the corner and never open it again, in terms of bad situations or bad patient outcomes. But
yeah.
there's also so much you can control and so much you can't control. Um, I think I do. Everybody has their own faith,
Hmm.
their spiritual faith. And for me, I think that helps me out a lot, right? I was raised Christian, Catholic, and obviously there's times that we have different reflections on our faith and how important it is, or questioning our faith or that. But I think
Yeah.
for me, I think it's been something that's really helped me through these situations, because a lot of times I feel it's out of my power, right? Like sometimes these things, like I can do the best I can,
Right.
but ultimately, it's not up to me.
Yeah.
And I don't know, my mom's a nurse, and she said one time, like, sometimes I just pray that, like, that what I'm doing, trying to put an IV in, like, these hands at that moment aren't my hands, they're God's hands,
Yeah.
and that's always stuck with me. I've always thought of that, like, give me the power to do the best I can, or maybe this divine intervention is what helps me get through some of those moments. And I don't know. that's true or not, but from my experience, I feel it to be true. Especially with these difficult cases or stuff in Peru that we'll probably talk about in a little bit. But like, right,
Yeah.
we did work in remote Peru, and it's amazing, some of the miracles that kind of happen. So
Did you find any of your psychiatry or any of that sort of thing like playing a role in helping out? Like without getting too much into like faith and what that means to you
yeah,
specifically, I'm trying to dissect that, but necessarily unless you want to. But did it help you like psychologically, or like how? In what ways are you supported by your faith or your spirituality? Or giving up control is so hard. Everyone wants control. And it's like when it's taken away from people or they feel vulnerable, they tend to like lash out or be scared. And you're kind of stuck in a place of vulnerability, even though it might not be your life on the line. It's your psyche and
yeah,
it's your reasoning.
yeah. Um,
Did that
it's not all rainbows and unicorns, in terms of that, because there's times that it's devastating, and you do open that box back up and you just sit there and you let loose and you cry and you can't explain it.
does it do you open it up? Do you have it like that? Or does it ever come over you?
I think it comes over you, or a scenario that reminds you of something that happened before, and then yeah, I think most of those times it just comes over and you lose the control, right?
Yeah.
You think you have control. I think empathy is huge for me. I mean, for me personally, to be able to handle that situation, because when you say people lose control, most people that I'm taking care of have lost control,
That's true.
right?
Yeah.
They are sick. They've gotten to the point where they can't take care of it themselves
Hmm.
and they don't know what to do. Or they're in the hospital and they don't want to be there, but they don't have control over that, And so I
Yeah.
think every day the patients I care for have lost control, right? Unfortunately. And it's
Yeah.
very frustrating. So then having empathy, right? Because if they're upset or yelling at me, it's not really yelling at me. It's because, you know, they're restricted on, they're in a room, right? Sometimes our healthcare system isn't the best. I don't want to go too tangential here, but like
Right.
they're in a room, they're getting a diet that they don't like because they're not used to it, or culturally it's not their diet of what they eat at home. But we say, okay, you got to restrict your salt. You can't have this, because it's for the better of your health. And then you can't walk because we're worried about you falling. But, then we tell you you need to get up and walk because you
There's
need to get
no
stronger.
there's no lasagna. There's they don't maybe
Sometimes, but not everybody can eat it,
yeah.
depending on. And so, yeah, I mean, that just struck me as a point when you said like people always want control,
Yeah.
and I won't say that I'm not the same, but I think some doctors are very black white and want control, and it's my way or the highway,
Yeah.
and that's okay too, because I think sometimes um, I'm not maybe the most strict or direct with patients because I want to be empathetic and kind of hear their side of things and kind of appreciate where they're coming from. And I think some doctors are a little bit better like, no, this is, you got to stop this and do this now. So some people need to be spoken to directly, and some people need, to modify it a little bit. So I'd say, it comes with the territory to kind of figure out how it works. But yeah, I don't know. Kind of went on for a while there. I don't know if I answered
No,
any of the
yeah, you
questions,
totally
but
did. Yeah. So getting you do the 4 years of school, 4 years after, and then you do 4 years of training in pediatrics and internal medicine, and then where does it go from there?
yeah. So when somebody finishes their training, then they can go and do what they want to do, right? They got to look for a job.
Yeah.
So you kind of decide generally how do you want to do this. So I didn't do a ton of research. I was involved in different research projects and stuff. So some people will go and just do research, clinical research or laboratory research. So that's kind of one thing. Some people will stay in the training setting. We call that academic medicine. So they would stay at a major medical school or medical university hospital where they have residents and students that they're training. Um, and then some people go out to community hospitals, the most of the hospitals that we guys were involved with, especially here in the suburbs of Chicago,
Hmm.
and get a job or open up your own private practice, right?
Right
And
off the
so
bat.
right off the bat.
No
Yeah.
kid.
So but most people can't because you have med school, loans and everything. So people usually don't have the financial ability to just open up their own practice right off the bat. So you would join a private practice. So it's technically most of the way it goes. You join a group that's already established, but it's a private group, and then after a certain amount of years, you can pay in and then become kind of partner of that group.
Okay.
Um, and
Is
then
that like making partner? Is that like a business
kind
term?
of, yeah.
That's like if you're like an attorney, that's what you do, right? You like make partner or something.
Yes, yeah. So I mean, it's probably more known as an attorney, but
Yeah.
it's kind of similar in medicine. Yeah, because then your work hours are a little better. You're kind of part owner of the company. So if it sells to another practice, then because if before then you're kind of an employee, so you don't get those benefits. So yep,
Yeah.
it's similar to that idea of making partner. Yeah.
So there's a lot of ways, right? I mean, you could get big hospital, major hospital close by. Are you employed you're employed then, right? You're
Yeah,
not,
so it could be either way, right? So you can be employed by the hospital system. So some people will, and then some hospitals don't really have a bunch of employees, but they'll what they say contract with or give hospital privileges to the private practices, right? So if they need surgeons, they'll go to a group of surgeons and say, we would like you to work at our hospital. We give you privileges, but then that group's in charge of their own billing and
okay.
collections, or they're employees of the hospital, right? So usually somebody coming out as a physician is usually employed by somebody. They're the employee. So you're an employee of a private practice, you're an employee of a hospital, you're an employee of a university for the most part.
Not too many 1099s.
No, well, some people do that. Sometimes a lot of people just be like their own personal contractor, and then they'll go and fill in needs, almost like a substitute. Somebody's going on vacation or has maternity leave, or the person that was working there left and they don't have, like for me, an ID doctor. So if there's like a hospital in the middle of Indiana that needs an ID doctor for 6 months, so some people will do kind of what we call locum tenens. That's probably the last
Okay.
kind of way to do it. So some people will just do that. They'll go work someplace for 3 months and then take some time off, or just go 3 months here, 3 months there, 3 months there. So that's the other. I mean, there's probably many ways to do it, but that's another fairly common
Okay.
way to work as a physician. It's called locum tenens.
Locum tenens.
And if I was smarter, I'd realize what that Latin stood for, but it's pretty much
We could look it up.
yeah.
You
Yeah,
wanna look
yeah,
it
let's
up?
let's learn something.
Learn something. Let's look up locum tenens. How do I spell this?
LOCUM and then space and then DE. Yeah, there you go.
Locum tenens refers to a temporary, intermittent, or on-call medical provider who fills in for a regular physician or healthcare professional when they are absent or on vacation, or for other reasons. Essentially, it's a way for healthcare facilities to cover staffing gap basis. Yeah.
And then there's the answer right there. No, go
What's
back.
below?
It was with the next sentence, I think. There. The term is derived from the Latin phrase meaning to hold the place of. There you go. To hold the place of.
Is a lot of medical stuff derived from Latin?
Yes.
So if you go, when we were in the hospital, meaning me and my wife and I, for birth, like I was really excited to see a foreigner
Okay.
in our situation, only because I was like, oh, she's got like a good work ethic. Like I could see on her that like she's been sewing up a lot of people her whole life, and she had like a really strong accent.
Uh-huh.
Does it make it easy? Is like being a doctor one of the things that kind of makes it easy because like it's common terminology, or is it just like kind of a basis? Like,
It, it's like a language. Actually, I remember in med school, our first month, they said when you come here and you start learning medical terminology and words, you were going to learn over, I don't even remember, but several thousand new words, and you'll learn a new language. And that's what it is. It's like learning a new language. So I think going through medical school, just the way we write prescriptions, we see people don't eat. We say NPO, right? NPO.
what's
And
that?
again, I'm not totally Latin, but it means nothing by mouth, right?
Okay.
Some not a poor aura. I speak Spanish, so I'm probably making that first N up, but
Yeah.
And so a lot of phrases and stuff we use are derived from Latin. So I think we just learn it in med school. So it's like, yeah.
It's like a brand new language. It
Hmm.
translates.
Yep.
It helped you a lot because eventually you made it to Peru.
So
You know. So where did you get hired? Where was your first? Did you go on a lot of interviews? Was it the first one? Did
yeah, so I don't think I took the typical route, right? So normally, what as I finished MedPeds training,
mm-hmm.
I would have taken jobs, um, or interviews at either of these places that I was looking at. But my wife Antoinette, and she practices family medicine. She was a couple years ahead of me in training, so she was already done.
Okay.
And she took a job at a community hospital that had a training program for high risk OB. So she mostly was working in a community hospital, but also was responsible for training fellows.
What's high risk OB?
Okay, high risk obstetrics and
What's obstetrics?
attending to pregnant women.
Okay.
So she was, it was maternal child health technically is what it was. So it was, you know, normally family practitioners,
Mm-hmm.
especially back several decades, were the ones that primarily did deliveries. They were the family doctors. They did everything. And then as we started becoming more and more specialized, we have the OB-GYN doctors, obstetrics, gynecologists.
Mm-hmm.
And then they became more specifically women's health and specifically, prenatal care and deliveries and C-sections. So as that grew, family medicine was doing less. But there's still a small minority of family medicine doctors that carry the torch and do full scope medicine and deliveries, and she does that, and including not just regular deliveries but training in C-section. So that's what she did. She did that training, and then she worked in a community hospital training other family medicine doctors to do that. But we had done some short-term mission trips or global health trips, to different parts of Central and South America. A few of them together, a few of them separate, and we just
That's after your
this was during
training.
this was
So
during
during your
training.
training,
Yeah.
okay.
So the
Did you
first time,
train with her? Are you allowed to? Is that a
so well, she was ahead of me. So
okay?
so I we actually when I did my family, that third and fourth year of medical school,
Mm-hmm.
when you do the rotations through the different divisions, I did my 6 weeks of family medicine training
Mm-hmm.
through the Cook County Family Medicine Program, the Cook County Hospital, the world famous Cook County Hospital.
Is it?
Yeah, yeah. And she was a family medicine resident, and so that's where we initially met was through training.
Oh,
So
no kidding. That's how
yeah.
you guys met.
Mm-hmm.
So you didn't have a relationship, and she gets you in.
No,
You met there.
no.
I was gonna say, wow, that's
So yeah, so that's where we met, and so during training, the first time I left the country was after my first year of medical school. They called them ISI trips. Man, I got to remember all these acronyms, but it was a service immersion trip,
okay.
Ignatian service immersion trip, because the Loyola or Jesuits, right? So Saint Ignatius founded the Jesuits. So these ISI trips were called Ignatian service immersion, and so they were usually between, I think, 2 and 4 weeks, because that was really the only summer break we had. Once you get to med school, that first year you do your classes,
Mm-hmm.
you get a little summer break, and that's where I think we had maybe 6 or 8 weeks, and a lot of us chose to go on these trips. And then once you come back, you start second year, but then right when you finish second year, you take your one of your step one boards,
Okay.
and then you go right into your clinical. So like that's kind of your last traditional school year where you get a break. And I went to Guatemala, and I don't know what it was either. I just being there and seeing the need. It was the first time I left the country.
You went when you say immersive, you went to practice.
Yeah,
It
yeah,
wasn't vacation.
right.
So you took your break to continue to not be on a break. You
Yeah,
took your break abroad and went deeply immersed in
yeah,
is that a third world country?
yeah.
Guatemala?
Technically, yeah. So it's in Central America, and yeah.
What
So
were the
they're
differences
considered
like?
a low income country, right? So they usually use a low medium country or developing country or first world, third
Okay.
world. So, but yeah, so they were considered uh, low income country, third world. So for me, it was completely eye opening, right? Like just to walk into the airport, just the coming out of the airport, I should say, and getting into the vans and seeing the military personnel. It wasn't like they had problems, civil wars in the 80s, and a lot of terrible things happened. But you see, like guy in army fatigues with like an M16. It's like, whoa, like we just see our regular police officers, and their holsters, and so like to see kind of like, well, what is this? And then just seeing, I mean, from the Midwest, I didn't travel a ton. I never left the country, and then you see the mountains and the mist up there, and the
You had never left
coffee,
the
and
country before you going to Guatemala?
no, no, never
Yeah,
left.
that's
Oh,
how old were you when that finally happened? Because it's a lot of schooling before you
yeah.
get there.
So I would have been 22, 23.
That's
Yeah,
it.
right about there.
I was gonna guess like 30. I mean, obviously the math
Yeah,
puts you
because we
there,
do
but
what, you finish high school at around 18, and then college is through 22,
yeah,
right? If you're kind of on the standard trajectory. So yeah, so it was
right.
after, yeah, so about 23.
Okay.
So, but yeah, those are, I, I we went with, there was probably about, we went to, there's many different countries that people could go to, maybe six or seven.
Mm-hmm.
And so we had about, the groups were between 6 and 10 medical students. And then we would go with 2 or 3 faculty, right? So physicians who worked full time at the university who took their time to go on a trip with us. And we went into there was a small clinic, and they would actually take volunteers. They had a clinic with full time doctors,
Mm-hmm.
and then they accepted volunteers year round to go to these little outlying communities, and they had little medical records set up. And so, each month different volunteers would come in, but I could see what the last volunteers wrote. So there was some continuity, which I liked, because, we went in there, and you go somewhere for 2 weeks, you can't do a big difference, right? You might feel good and think you did something good for yourself, or maybe you helped 1 or 2 people, but in the long run, what did you do? So it's always nice to join something sustainable, and everything can be better. But I thought they had a pretty good system going,
Yeah.
and so seeing that, and just, I mean,
Got to open your eyes, right?
yeah, I mean,
Because you see, like, we're the superpower in my eyes, right? America has like
yeah,
all the advanced technology, and then you're kind of put on the bottom side of that. Did it give you a different outlook on medicine, like in itself, like maybe its history or like kind of where it came from, like actually? Because it's, I don't mean this in a negative way, but being more primitive, it's more about like life or death
yeah,
than like, maybe conceptual things or
yeah. No, that's a good question. I think the differences, strike you right away in terms of, we get in the back of a pickup truck with duffel bags with some medicines or stethoscope, and you get, some rehydration packets, and you get out there, and they had a good vaccine program too. We weren't doing specifically the vaccines on our trip, but I mean, they're coming from little dirt shacks, and we're attending to them in a very dark kind of school room, which, has natural light or our little otoscopes to look at. And there's
yeah,
certain things that we could fix and really help out, rashes that are really bothering them, arthritis, they get an injection in the knee. That's going to help them, because day to day they're walking, and they're going to collect their firewood, right? And so if their knee's not hurting so much for 2 or 3 months,
yeah.
that's a real thing, right? That you're helping with. The primitive aspect of medicine, I didn't really, that part for some reason didn't get in my head, maybe because I wasn't there long enough with these shorter term
Maybe
trips.
because you were 22.
Yeah, probably that too. And I didn't know as much medicine either, right? Because you're
Yeah,
just starting when we did these trips. When I got to Peru, I was like, oh, this is kind of where medicine came from. This is what we were doing in the 60s. Or this stuff really worked, and it hasn't changed much because it works.
yeah.
So I noticed that type of, maybe the history of medicine and how things have evolved more when I was in Peru full time. Yeah.
Okay. So, where did you got hired? Where'd you get hired out of? Where was your first job?
Yeah. So my first job is, I didn't do the standard interviews and jobs because Antoinette and I had done these short term trips, and we said, when
Yeah.
I finish my training, because she was already done,
Mm.
then we're going to go abroad somewhere for a year.
Oh,
So my
really?
interviewing, what we were really just looking for organizations that we could go with and partner with, and work for a year and kind of volunteer.
So,
And
right out of school, you went right into basically other countries, like hands on.
that was the idea. But with everything, it costs money. So we had kind of known this for a year and a half. So we were kind of living off my resident salary and saving up, her
So
salary.
you went to go do work that wasn't paying you.
Yeah, yeah, yeah.
Wow. So you're like a good doctor. I'm not trying to say it's bad to get paid. If you didn't get paid, nobody would eat. I'm not
Yeah,
saying that. But that's so you're really coming at it from a place of empathy. I mean, you really are. I mean, obviously.
yeah.
And so what was the first trip like? Where'd you go? What'd you do?
Oh, well, we still did need money, before we left. So my
Hmm.
first job,
Okay.
technically, was a moonlighter, and I think we talked about this a little bit before. It's not quite the locum tenens,
Hmm.
where you're there long term, but if they need extra workers or to cover some shifts in that, they usually will look internally. And so since I trained at Loyola is a big university hospital, they're partnered with the Heinz VA, the Veterans Hospital.
Okay.
And so the Veterans Hospital had opportunities for like night shifts. You cover the ICU at night, and that would be covered a lot by the ICU or young cardiology doctors.
Okay.
And then the emergency room could be covered by young emergency room doctors or young internal medicine doctors. And so that's where I fit in. And because I trained there, I knew some of the people, and they're like, well, I'm like, well, we're looking for a place to go. We're going to go within the first year. We don't
Hmm.
know where we're going yet, and I'd like to save some money. So my first job was a moonlighter, which means I worked the night shift at the Heinz VA ER. So, and they weren't just the night shift. They were like a double shift. So I would start at 4 in the afternoon and then finish at 8 a.m. the next day. So 16-hour shifts.
How does that not? I've worked a few 16-hour days straight. Uh, how do you stay sharp? Like, how is that? Is it effective? Is it just like, that just sounds so, it sounds irresponsible, honestly.
Well, after doing many 30-hour straight shifts, the 16 hours don't seem so hard.
Is that a big part of it? I don't know. I haven't really discussed this before. Do you,
Yeah, so I get it's conditioning. Now it's hard because you got to be on right for 16 hours. But I think there is that. I don't think it's unsafe after going through it. To be
Mhm.
honest, I think your awareness is up, your adrenaline's going. There's a continuity of care that actually is beneficial, in my opinion, because some of the rules have changed, and so some of these shifts that I did when I was there weren't even as bad as the shifts that the generation before me did in their residencies. They
Okay.
called it residencies because you literally lived in the hospital.
Mm.
Like,
Right.
right, there was
Right.
times when they were in there, like their mail was getting delivered there. Right, when they were off, they were just in a room sleeping because they barely had time off. Right,
So
so
you're,
that was like the generation before me. And then when I was there, we would do our call shifts every probably about fourth day. You
okay.
go in at 7 in the morning or maybe earlier, just whatever it was, and then you would work for 30 hours straight. You would leave the next day at 12 or 1 in the afternoon.
That's typical.
You go home and sleep, come back the next day at 7 a.m.
Yeah.
Right, and then you would get usually one day off a week. And so we call that the post call day, right? So when you leave at 1, you're post call. And for me, it was great. I could go to the post office, I could get a haircut, all the stuff that people
Take a
take for
shower.
granted.
You
Yeah.
could close your
So
eyes whenever you wanted.
yeah. So what we would, when you're on call, if it was slower, which usually I could get 1 to 3 hours of sleep. I mean, we'd have like what we call a call room, almost
Mhm.
like a dorm room. There'd be like a nightstand and a bed, and maybe a locker. There'd be showers, so we can clean up.
Yeah.
But so when you did that every fourth night for out of the 12 months a year for 2 years, 4 years, when you come back and say, oh, you got to work 4 to 8, no, it was okay. And I had more control then too. I usually wasn't working 4 to 8 like 5 days in a row. I would do 3 shifts a week, and so 16, whatever that adds up to there. So
Yeah.
to 48,
Right.
48 hours,
Hmm.
so that having control if I'm doing it a Monday night and then like a Thursday and Friday, it wasn't. It felt like, oh, I have control, and the next day I'm totally free.
Yeah.
The next 2 days I don't have to go in. So
Knowing you get to go home probably helps you like put up with what you have, right?
yeah,
You're like, okay, now I'm gonna have a break, and
yeah,
there's relief, and
yeah,
then you find it.
yeah. And then the rules changed, right? They actually kind of eliminated these 30-hour shifts, right? They were saying, especially if, I don't know what the rules are right now, but it kind of changed like 12-hour shifts for first years, and then as you get older, you have more experience, you could do like a 24-hour shift.
Okay.
But then they would also have like more days off during the week, and so for health, it's true, it's probably better. But for patient care, I mean, when you have somebody that's critically ill and you see them in the ER when they're their sickest and you admit them
Mm-hmm.
and you start your treatment plan
Mm-hmm.
and then you monitor them overnight. And if they do okay, you don't have to do much. The nurses are there, but if they're really sick, you're with them all night.
Right.
And then the morning comes, and then you see how they were compared to they were in the ER. Are they getting better? Are they getting worse? You've put in all the orders.
Yeah.
And then in the afternoon, you're kind of like wrapping up, checking in, and you sign out to somebody.
Mm-hmm.
You've had 30 hours of acute care. And now with the rule changes, a lot of times, somebody will admit them and then they pass that off to somebody else at 8 p.m. And then they pass it off to somebody else at 8 p.m. So now you've had 3 doctors in a 30-hour period trying to, and things get missed or can get missed. So from one side of things, I think it might be harder and sound cruel, but from the other side, sometimes I think it might have given better patient care.
Yeah, no, the continuity I think is a big deal. I think you're right because too, it's probably like the inclination to just assume who was ever doing things before you obviously did the right thing, and they probably did. But like, say you're doing medicines or you're treating like a high blood pressure or you're treating something like immediately, you might not correlate it with like something they had previously been given necessarily right off the bat because you're like, okay, let's address this with what I know works, and it may be the result of something that was like done, especially probably like post surgery. I want to say post surgery. I don't know what was,
Yeah.
but no, I'm saying that because of a situation. But um, so they don't do 30-hour shifts anymore. Not
I
common.
don't think so. Yeah, I think some of the senior residents do. Maybe some 24 hours. But I don't think they push it to the. And to be honest, even though there's some, sometimes people stay longer. Sometimes surgery residents that, sometimes they're still scrubbed into surgery, assisting until 5 p.m., 6, you know what I mean? Like sometimes the days got pushed
Yeah.
even longer. So, yeah. So it's amazing thinking back that I did that, to be honest. Like now with 2 kids at home, I'm like tired by 9:30 and like I got to go to bed. Um, so, but I think it's pretty amazing when it's needed what our bodies can do, both as a physician and then patient care, right? In Peru, like there's some things you're like, oh my gosh, how did the body withstand what's going on with it right now?
Where did you see the most trauma, like physically in a patient?
Ooh, well, I think when you're in the areas of trauma, so when you're doing your ER rotations, or sometimes you even do specifically trauma. So we talk about super subspecialization, right? There's trauma surgeons, right? So like the emergencies that come in, a lot of times they kind of go through the ER, get stabilized, and then go to the operating room, or the trauma surgeons meet them right in the emergency room.
And that's mostly organs. Is that going to be like?
It'd be like car accidents, shootings, stuff that's like life threatening immediately.
So, but I mean, like they're the trauma surgeons or the trauma doctors. Are they normally performing surgery on vital organs, or
Yeah, I would say that would be pretty accurate. Yeah, yeah.
did you have to do that in the VA?
No, no. So we weren't technically a trauma center. So,
Okay,
um, yeah. So a lot of times the system's set up where the ambulances are going to take those to the places
the
that have the
trauma
trauma center.
doctors.
Yeah.
Okay.
So, so yeah. So no, I didn't get any too crazy stuff um,
Well, that's
at the
good.
VA overnight.
So you got that was your first job,
So that was
VA.
that was the first job. So the VA. Um, and then a few months after that, I also started doing some immediate care work.
Okay.
So that's kind of more like a clinic setting, and as I think most of us know, an immediate care or urgent care. So those were shift work. Those were usually 8 or 12 hour shifts, and a little more calm than the ER. And most of it, runny nose, backaches, knee pains, X-rays, stuff like that. You when you need to see your doctor and you can't get in, that's where you go. That's what we were seeing. So while Antoinette and I were looking for, where we were going to go do our work abroad,
Mhm.
that's what I did to help, get more money to save up.
Did you notice? And I don't know if you've been in a consistent specific area long enough, but have you noticed like a big increase just in like anxiety? Because I'm sure a lot of people come in for things that maybe like are not diagnosable or obvious. Like from when you started till now, do you think there's an uptick in it, or do you think it's just like more discussed, but not necessarily? actually happening more?
Hmm, good question. I think probably the latter. I think we've always had anxiety. I think that anxiety's changed.
Yeah.
Um, I think it's been stigmatized. Any, psychological or mental health concerns, right? The stigma behind addiction, stigma of depression, of anxiety, of saying that I'm struggling. I
Hmm.
think there's been a huge stigma.
Yeah.
I think that's improved, which has opened up the conversation.
Okay.
And so I think people are more willing to address it or speak about it before they weren't, because I think it's always been there. I think the types of anxiety or what we have issues about have changed. I think, just thinking of you and I, right? What was it like when we grew up as kids?
Oh, it
And
was
what's it going to
great.
be like for our kids, right?
Yeah.
And so these other stressors and, technology is great, but man, I mean, can you imagine like every stupid little thing you might have done in high school? Like somebody might have recorded it
Oh, right. And it
and it's going to,
follows you.
yeah, and you can't get rid of it, or they're going to use it to kind of blackmail,
Yeah.
we never thought of that. And
Right.
so I think that there's a lot different stuff there, but I think anxiety's always been around. Um,
Yeah. Makes sense. I wonder. You see it a lot and you wonder if it's like, is it really uptick? Is it more or is it
yeah,
just
it's a lot. It's a lot. I mean, I think when I did primary care, that was actually one of the harder things for me, right? So, after I did the moonlighting in the urgent care, we went to Peru. We ended up being there 4 years. But when I came back, I did primary care, and actually, that was one of the things that surprised me the most, is how much um,
stress?
anxiety and depression I was dealing with day to day, right? If I'd see 20 or 25 patients in clinic,
Hmm.
a quarter of them, they weren't there for blood pressure, diabetes. They were there for anxiety or depression.
Did you
Probably
find
25%
a quarter?
of my patients every day. I
It's a
was
big
acting
number.
more like a
Psychiatrist.
psychologist,
Yeah.
counselor, you know, and even though, like you mentioned, we have some training in it,
Yeah.
but that's not my forte.
Right.
That's not. So there's a lot out there.
Speaking anecdotally, I was having some situations with like, I didn't want to call it anxiety because I never really had it. And I'm not like a stress, I'm kind of more of a daredevil type of person, you know? I mean, I'm a physically active person. And I had a real hard time like doing certain things. And I was calling it like, I'm just like, I feel like I have adrenaline or cortisol. Like I'm trying to put names to it, which I'm not a doctor. So when I tell that to a doctor, a lot of times they're talking about cortisol for, you know? And, but in my like discovery of myself, I found that like it was really rooted in my diet, like in a large way. And by eliminating certain things, um, like it like virtually kind of went away. And I just wonder if that has any sort of relativity in our society today, and if it's maybe more commonplace than we realize. Um, and like, how can you like? Because it's so subtle, right? Like inflammation and different
Yeah,
things like that can be so subtle, and there's this idea that like there's mental health and then there's like health, and I feel like obviously the more you learn, the more you compartmentalize things to have special things. Um, but I almost feel like it's not separating it is like a really important thing. Like, I said like there's, and I'm not obviously, I'm now a doctor. I have no, I can't, I'm not giving medical advice by any means, but like they're like, it's the same thing. Like I don't think you can expect to have good mental health if you don't have good physical health. You might,
and I think vice versa.
yeah.
Yeah,
So, that's just something that I thought for me was kind of like very eye opening. And I was like, and part of me didn't want to accept the fact that like someone was telling me I had anxiety. And I was like, no, I get it. Like I have a hard time. And like the way it was being like re-propositioned to me as like, oh, like you're like obsessing in your thoughts. And I'm like, no, I have no thoughts. It's like a very biological, chemical feeling in my body that just feels like I'm shedding like this like something inside of me that's like that needs to leave. Like
Mm-hmm.
And and over time I began to try, to figure it out, like I had to, because it was limiting me. I was having like situations where I couldn't really or I had a hard time driving, or I had a hard time like um mostly driving, or like being away, um which doesn't seem relevant to necessarily like my chemistry, but I noticed a chemical response. Like I didn't
Mm-hmm.
feel like it was psychological. It was very physical.
Mm-hmm.
And then so because of that, obviously the mind is very powerful, and so on and so forth. But I I did only find relief in changing my diet, which I'm not saying is the case for anybody, or they should take that as like,
Yeah.
oh, maybe if I stop eating this, and then, I could not take these medicine or something like that. That's not the case. But I just think it's interesting because for me personally, it's like there's certain things I can't eat, or like I'll have like really bad vertigo fits.
Yeah.
But like it compounded, and I'm glad it happened, because sometimes these things just sit by subtly, and then you get to be 45, 50, and you have like a real difficult situation you can't get out of because you've had certain inflammation or certain deficits because of, let's say, tendencies, or maybe my diet was terrible and I should have been paying attention.
Yeah.
So I like that it made me reflect early on, like in my 30s, and I didn't have a choice but to like try to be like very healthy. And now I'm like very happy being very healthy. And I
Mm-hmm.
notice like how much it improves my like mood and things like that. So without being too long winded and getting off track, I just, I wonder.
I think you said something earlier that was pretty profound. Is as we get more specialized, we compartmentalize, and I think that medicine's very guilty of that, especially the way we're trained, right? And so, in terms of medical school, there's MD, medical doctor, which is what I did. There's also
Mhm.
doctor of osteopathy, where they do a little bit more um, anatomy, biological tendencies, adjustments, right? Like you're carrying stress here, this muscle's here, this rib's out of place here, you
Yeah.
know, where we compartmentalize, oh, you have musculoskeletal pain, do an anti-inflammatory, Aleve, naproxen, Advil, where it kind of, are you addressing the root cause? And I'd say that's probably a big deficit of medical training, because it's so broad and expansive. There's so much to know
Yeah.
that we start compartmentalizing, and we're taught, if X, then Y, or if A, then B.
Yeah.
And so what you're saying is true. And I think that's probably an unfortunate side of medicine, is with the way we're taught um, in general, is everything you're saying is anxiety, right? And so
Mhm.
we're going to say, not for you, but for the patient, oh, that's anxiety. Well, what's the root cause, right? And
Yeah.
so, and
That's
the
what I
thing
was.
is the two things overlap, right? Because if you have physical stress, think about, and I think anybody listening could say this, well, think about something that's been really difficult in your life, whether that's being a death of somebody, or an accident, or a traumatic incident where you have PTSD, or something that's made you so upset,
Mhm.
a loss of your job, stress about paying your mortgage, whatever it is, like, right, that physically affects you. You're
Absolutely.
nauseous, you lose weight, you don't, like, you don't
Mhm.
sleep, and then it can become a cycle, right? And so your mind affects your physical well-being and how you feel.
Yeah.
Or like I said, vice versa. If you've had a car accident and you hurt your shoulder,
Mhm.
and you used to be, a rock climber, and now you can't, do anything because your
Right.
shoulder needs surgery, or it hurts and you just can't do it. Well, then you can't do what you wanted to do. So then you become depressed. And then, so it's like it can go both ways. And I think a lot of times we're taught to know the answer, or, you know, come up with, these are the 20 things it could be. And then we're going to go through the process of eliminating 19 of them to come to our answer. That's a little bit of how medicine is.
Yeah.
And so when we can't answer it, certain doctors respond a certain way, right? Like certain people might say, "Oh, well, that patient's crazy," or that
Yeah.
patient doesn't know what they're doing, or I don't know what's going on, and the patient's gone to Google and looked up 800 things and says, and sometimes that can be annoying because it's like you didn't get any training. But the other side of the coin is, well, maybe maybe I know about these diseases, but I didn't think about them.
Right.
And you looked up three things that this potentially could. You looked up 300, but these three actually might fit the thing that I didn't think about.
Right.
So it's also that, just ego. And I don't think that doctors got to be top of their class and get good grades and get good board scores and work 30-hour shifts without having some sort of ego,
Well, you got
right?
to trust yourself. You got
Yeah,
to, right? I mean, you have to identify with yourself. And if you're in the habit of questioning what you're confident in, that's not a good
right,
thing.
right.
But yeah, there's kind of like maybe the idea of like you said, the doctors that tells you, hey, this is how it is. And if you're not willing, maybe they get very frustrated or like fed up with you.
Right.
But I don't know if that's a big part of it. I don't know. I haven't
Yeah,
seen too many doctors. But yeah, I'm sure ego is something everyone tries to work with having less of.
yeah,
You don't want to have none of it because then what do
right.
you just take on you just you know then the patient becomes the doctor and how effective are you going to be maybe so so after your training you went to Peru. What was the what was that like? I mean,
Yeah.
how did
So that was thinking about it now. I'm in my mid 40s. I mean, it was probably like the biggest decision I made.
how old were you when you went the first time to Peru?
Yeah. So Peru. Now we finished the 4 years of med school, the 4 years of med ped. So I think I was 30. Now I'm 30. I'm 30 years old. It's kind of that's as medicine, and doctor, we kind of really postpone our careers, right? Like friends that are getting out of college, they get good jobs with, some finance firm, they become partners in, their firm or their thing,
Sure.
um, you know, and they're 28.
Yeah.
They're 30.
Mhm.
And then it's like, oh, I'm just coming out for my first job interview, so it's a little humbling in that regard. But so yeah, so I was 30 when we went to Peru. We had looked at different spots of organizations. So we looked at Doctors Without Borders.
Okay.
Interestingly for us, and the schedule I just told you about, and Antoinette was working, as a physician. So we weren't necessarily home every day. There would be, spurts where we'd go 4 days without even seeing each other, talking to each other. We'd live together. We wouldn't even see each other. Um,
No kids at the
no
time?
kids at the time. So we got married right before I started MedPeds residency,
Okay.
or, kind of that year. So during training, we had no kids. So that was, 3-4 years. So we're
Mhm.
living together. But yeah, there's times that we wouldn't even see each other just because of schedule. And when we talk to medicine or Doctors Without Borders, uh, they don't allow couples to go on trips together the first time,
The first trip.
the first trip. And their trips are usually a minimum of 6 months.
Oh, wow.
So we're like, we already don't see each other. We're newly married for, it's still a early marriage. And it's like, then we're going to sign up for an organization that sends us to 2 different places around the world. And they go to riskier places than a lot of other organizations. So we kind of X them off the list. And there's a couple other organizations. But ultimately, we ended up in Peru because Father Jack McCarthy,
Okay.
Padre Jack, is, a friend and a mentor to me. And he'll always be that. Um, and he was a Loyola graduate, and he, with another priest physician from Canada, Father Mo, um, they had worked together in the late 70s in Peru in the high jungle. So Peru's the coast, the Andes Mountains, then you kind of go over the mountains, you have the high jungle, and then kind of the lower jungle down by the Amazon. And so when Jack finished, he was a priest already, he finished medical school at Loyola, and he wanted to go to India to be a missionary, and he didn't get his visa approved. So he got a visa for Peru for 1 year, and because he's a part of the St. Norbert's Abbey up in like Green Bay, Wisconsin, De Pere technically, but it's a
Does the government you're going to, do they have to approve your visa? Obviously, right? It's up to them. Like Peru approves.
right, yeah. So it depends on what countries, sometimes there's reciprocation, or sometimes you don't need a visa. So it just all depends on the country. So back at that time when he was applying, you
Mhm.
needed a visa to go to India as a U.S. citizen, and or at least a missionary. And so whatever visa he applied for, he got denied. And so they're like, oh, just go down to Peru for a year, because
Mhm.
they had other priests working there, but they weren't doctors. They were working in a high school. And
Mm.
so he went down there, talked to him, and they said, hey, we know another doctor in the high jungle. Um,
Yeah.
why don't you go check that place out? So he checked it out, and that's where Father Mo was. And so they worked there in the 70s for about 2 or 3 years. And then unfortunately, there was a lot of terrorism and civil conflict in the early 80s in Peru, the Sendero Luminosa. And so they left because it was too dangerous.
Hmm.
And they kind of split up and so Jack actually went to San Lucia in the Caribbean and worked at a Catholic hospital there for 3 years. And Mo did research on leprosy in Haiti for 3 years.
Oh,
And then when
wow.
things calmed down, Mo always wanted to get back to Peru. So he went back to Peru, kind of similar, within the Catholic Church. Where are we going to go? Found out there was a bishop in the Iquitos area in the jungle. And so that's the state of Laredo. So that's the northeast of Peru. Huge space, like the biggest Texas, but very small population. But they had missions all along the rivers there, and some of them had health clinics and outposts. We said, I need somebody to help run these outposts and start the clinic. And that was back in 86. So he went there, checked it out, said, oh, this is a good place to start. And then he said, well, I'm going to let Jack know in St. Lucia. And so Jack came. And so the two of them started this clinic in 86.
So are they actually priests then? Like doctors
Yeah.
and priests?
Yeah. Yeah. Yep.
So they're like actually saving people. And I'm not putting down missions, but then the other missions are just being like taught Christianity specifically. Is that kind of like the way in? Like, because if they're
Yeah.
not doctors, but there's a mission there, what's
Right.
taking place?
Yeah. So,
good-
running a church.
Okay.
So what we would do here, like, so they need priests to run the church or nuns. And there's a couple ways to think about mission. And, because sometimes you can think the TV, like they're evangelizing the whole time, right? They're like preaching about God. And then there's other mission of just like walking with the people, right? Like,
Yeah.
and I saw a lot of that on my short-term missions where they were just meeting the people where they're at.
Yeah.
And leading a religious life and obviously praying and going to church and doing sacraments, but they weren't preaching.
They're not like trying to convert people and make them.
From my experience, right? Because I think that's really, personally, I think that's like trying to, impose on somebody your will. And
Yeah.
and so the way I like to think of it is your mission is your example. And that's what I viewed from Father Jack and Father Mo, right?
Yeah.
What they did day to day. So they would go to mass. They would celebrate the mass at church, right?
Yeah.
When they go to communities and if it was a Sunday, they would say mass in the communities. And
Mhm.
then, the day before, the day after, they're taking care of the patients in clinic. And, they're baptizing. And so they had all the skills. So, but you're right. I mean, I didn't personally see much like, hey, we're evangelizing to the point like you need to convert and, you need to do this just to even get into our clinic. I didn't see that at all. But they are. I mean, they're both retired now.
When I think about mission, I think more like in the realm of like medicine. I have a hard time with religion in general. I mean, I think like even very religious people that are actually religious, it stems from like a spiritual side. They're not necessarily like, you don't adopt this religion, then, you're not saved. And I think anybody that kind of takes that position is kind of hypocritical. And I'm not, you know what I mean? I don't know. To some degree, I'm sure there's like radicalists and it's like totally specific. And if you're, you're,
Right.
But I just mean in general,
Yeah.
like, I think the fundamental things that are important are always important. And those are good to keep alive. And it's good to have like diversity amongst all communities and perspectives, right? It's got to be great to have someone from America, their perspective, their insight, and vice versa. And then I think the medicine is kind of really, that's the mission because you're bringing something that's not so abstract. I feel like religion is very abstract, at least in Catholicism. It's a lot about belief in what you think.
Yeah.
And not that there's anything wrong with having good thoughts or, thinking good things or whatever. Right. But, like being pragmatic or the pragmatism of it, I think is kind of really universal.
Yeah.
And that's just my biased way of like being accepting, I guess.
Well, I think that's I agree with you on the spirituality front, right? Like, it doesn't matter what religion you may know or abide by or feel. I think there's just a basis spirituality that's universal.
Yeah.
And so some people would argue with me on that one, but right?
Yeah. I thought you were going to argue with me on it for a second.
No.
I'm glad you didn't.
No, I mean, I think there's that and I'm referencing things, and I hope I'm not butchering this example, but right, the elephant, right? Like you're in a room and
Mhm.
it's dark and there's an elephant there,
Yeah.
and that's kind of religion, right? That God is the elephant, but this religion is touching the trunk, and this religion is touching the leg, and that's how that's how you recognize the God.
Yeah.
But maybe it's all the same one, and we just see it from different viewpoints.
Oh yeah.
So
Yeah, I think so.
I didn't make that up, and I don't know if I even said it right, but that's what I've discussed before with other people, and people have discussed with me. But I think that's true. But
We got an elephant here that someone gave.
there you
Anytime we
go.
talk about elephants, you got to be on the right track. I don't know why that is, but I feel that way.
Yeah.
Um,
So anyways,
yeah,
getting back to Jack,
yeah,
so he would take, I talked about third and fourth year, you can rotate and do different things as a student. But one of the things that at least at our medical school, is we allow students to do a rotation abroad. And much like the service immersion trip, you could go and be supervised by somebody, and so that's what Jack did. So Loyola students could go down to Peru for a month and
right.
work with him in the clinic,
And that's work. That's part of your
and it's part of your training.
requirement. Yeah.
Yeah, and so I, at that point, ironically, didn't feel I spoke Spanish well enough, so I didn't sign up for the rotation. I was like, "This sounds awesome," but because they said you have to be fluent in Spanish,
Mhm.
and I'm like, I don't think I'm fluent. I think I'm just okay.
Yeah.
And so that personal fear that I didn't speak Spanish well enough kept me from actually going to Santa Clotilde when I was a medical student I was probably 24 at this time now, right? 24, 25. And well, it comes full circle. So I had classmates that went down there. Antoinette had a colleague from Peru who was looking for different places to help out and went there for a month because she heard about it.
Yeah.
And then he came back and said, I'm looking for people. He always is looking for people to recruit because it's hard to get people to come down there, especially long term. So when he heard through the grapevine that there was two doctors,
Yeah.
a couple that were looking to go somewhere for a year, yeah,
He was happy about
he
that.
sought us out, and actually it was funny because I was on call,
Mhm.
working my long shift, and Antoinette, because her friend knew Jack
Mhm.
and set them up to like have a meeting or have dinner together. She came home the next time I saw her. She goes, "Oh, we're going to Peru. That's where we're going to go and do a trip." I said, "Oh, that's good. Don't you think I should be part of this decision?" So,
He knows
and
what's
then,
best.
yeah, yeah, she usually does. Oh, the next day, interestingly enough, I was at the medical school because it's right next to the hospital. So I was over there talking to some friends in the office, and then Jack walked in, and I wasn't planning to meet with him, but
Mhm.
somehow I wasn't busy with a patient in the hospital, and I had like an hour, and I sat and talked with him.
Yeah.
He's like, I'm like, "You're Jack." He's like, "You had dinner with my wife last night," and then he talked, and then I got home that night, and I said, "You're right. That's where we're going." And
Cool.
so, sight unseen, we decided to go, but we knew a ton about it, right? By sight unseen, I mean we weren't physically there yet, but we had pictures, we had stories, we knew. At this point, we knew 5 people that had been time with Jack, and we, had met Jack, and we met him and talked with him many more times in the months leading up to when we decided to go.
Yeah.
So that's kind of how it went. I don't know if you remember, the family and everything just kind of getting ready to go. It was, yeah, we were excited.
Yeah.
It was, but that's how it happened. And so then we got all our passports and our paperwork's in order, and get our finances set up so that we could, get our loans paid off while we were there with the money we had, and
So you
we
did,
picked up and moved
and you,
to
and you
Peru.
for 6 months,
A year.
a year
A year.
straight.
A year.
The-
So we did come back. So the visas, you were talking about the visas.
yeah.
The visas only allow you to be in the country for 6 months straight.
Mhm.
So you had to leave and then come back,
Okay.
unless you apply for like the work
Extended.
visa or other stuff. But that took so many months to get approved. So, and then we weren't fully obliged to 100% stay there. So if there was like a big wedding, I think we came back for somebody's wedding that first year, and so, but it would, it served the purpose also of kind of renewing the visa by leaving and then coming back in. But yeah, so we were committed to Jack. We said we'd go for a year. Oh.
Well, what was well, financially then, like, how does that, so you have to figure that out yourself. You're not getting paid while you're there.
Correct.
So basically, like, what people pay for is like maybe your livelihood back home so it doesn't lapse, so that when you come back, you're not like totally in way more debt because you have student loans and you're paying your own way.
Yeah,
And
that's the biggest issue,
and is
to
it
be
just like
honest.
gifts, or like if you just like, what do you do? What do you
What do you
say?
mean?
Please pay for my bills. Like, do you apply for
No.
grants as a government? Is it people you know?
Yeah.
Is it through religious
Right.
organizations or?
So the beginning, when we just left, remember we were kind of living off my salary and saving Antoinette's salary.
Right.
And then when I finished and when you do the moonlighting, it's a huge step up in pay from a trainee,
So you were saving.
right?
You were putting.
So pretty much 90% of what we earned those 2 years were to save up so that, yeah,
You
when we were
could.
gone 12 months, the, the, the loan repayment, that's the biggest one really coming out of med school is the loan repayment, and I think our cars were paid off, but like our car insurance, and we could put it
No kidding.
into deferment while we were gone for those months, but then
Yeah.
reactivate it. So just kind of all those little things. But yeah, for us for that first year, it was just 100% dependent on us.
You financed that yourselves between the two of you making the sacrifice, putting money mostly.
The first year, yeah.
Wow.
And then we
Wow,
got
that's
towards the
amazing.
end of that year, and we realized, well, we're running out of money. Jack's like, please stay. We didn't have kids.
Yeah.
There was a huge need. We were pretty comfortable, so we're like, we want to stay, but we cannot stay. Like, we literally cannot stay if we don't have a way to pay
So
some of these things back home.
are you just practicing medicine there, like yourselves? Like, are you the doctors that are there? People come to you for service. Are you
Hmm.
performing surgeries? Are you doing deliveries? You're
Yeah,
doing all that.
yeah. So Jack helped us because he's been there so long. We went to the Colegio Medico, the medical college, presented ourselves, got temporary licenses, and yep, went upriver and worked every day.
Went up river in what? In a canoe? Is that real? Or are you just like
That would have
you?
taken way too long to
How
get
do you
there in
go
a canoe.
up? How do you go upriver in
Yeah.
a canoe?
Okay. So yeah, so I guess we haven't talked about this. So Peru. So where were we at in Peru? We were in the very remote Amazon jungle of Peru.
You said the high jungle.
So the high jungle is actually, we were in the low jungle. So the high jungle is kind of on the side of the Andes, where the climate changes enough to become tropical, but it's still elevated from sea level. But so Peru it's a beautiful country and it has many different types of cultures because of the geography so distinct. It kind of separates things out. So you fly into Lima, which is the capital city on the coast,
Okay.
and then you have to take an airplane to Iquitos. So Iquitos, if I'm not mistaken, I think this still holds true, is the largest populated city in the world that's not accessible by road.
Oh wow.
So we fly from Lima to Iquitos, and everybody's like, "Oh, what do you fly?" Well, we fly like a 737. It's like a normal flight. It's not a little prop plane because it goes over the Andes, and so it's Lima to Iquitos, and Iquitos is a very touristic area. It's a lot of people go there for ayahuasca, traditional treatments, or to see the Amazon.
Hmm.
And because it's a big city, they have hotels and stuff. Um, so we fly into Iquitos. So that's the capital. There's a regional hospital. They have some services, CAT scans. Now they have MRIs as well. Some local hospitals. And that was where the bishop's office was. They're the vicariate. They would call them dioceses here, but that's kind of who Jack partnered up with. And so they had offices there. So a lot of times when we go to Iquitos, we kind of stay there as our home base. And then we take the boat out. So where's the boat? So the boat is, we leave the docks there in Iquitos. We take it an hour down the Amazon River.
Hmm.
And then to make it a shortcut, we do cross a land bridge, a little town called Mazan, and we take a little moto taxi about 15 minutes to the other side, which is where the Napo River is. So the Napo River originates in Ecuador,
Okay.
and it's tributary that goes into the Amazon. So it flows a long, long way, and it's a huge river.
Hmm.
Think like the Mississippi River, like it's big.
Hmm.
From Ecuador, it gets all um, the water coming down, like some of the mountain ranges, right? So they get
It's moving.
glacial and rain because it's the
Yeah.
rainforest. And so it's a big river, and it flows from Ecuador all the way down into the Amazon. And so
Okay.
the area where it meets the Amazon, we could technically go there and then come all the way around, but that like makes the trip 3 times longer. So, anyways, we take the boat an hour,
Yeah.
we cross this little land bridge, and we get to the Napo River. That's where our health center is, in our the population we serve. So then we get in a boat. It's a motorboat, so it's a commercial motorboat, but there's usually only one a day, and it's probably about I don't know 40 feet long,
Hmm.
and they have little benches or seats, almost like airplane seats, meant not that comfortable, but maybe a desk chair kind of. Think about that size, right?
Yeah.
And so they usually have about four to a row, so about 20 to 30 people get in those, and it's kind of a commercial business, right? You pay a ticket to get there, and but it's very simple. Um,
Are you staying there, or are you commuting every day down
okay,
this path?
yeah. So no, this is so, and then
This
we
is
go
like
upriver 5 hours, so it's like a day trip to get to where we're going.
okay.
So there's one boat a day.
Yeah.
So you could go up one day and down the next day, but it's not a daily trip.
So you're there.
Yeah.
So
So
once you're in, you're kind of in.
but once we get up to the town called Santa Clotilde, so it's an hour on the Amazon and then 5 hours on the Napa, so it's 6 hours. So you leave Iquitos at about 5:36 a.m.
Okay.
and you get to town at about 2 or 3 in the afternoon.
Oh wow.
So yeah,
You set up so you go to something that's pre-established. They have it's a hospital there. Is that what you're
yeah,
going to,
yeah.
more or less? What's it
So
made out of?
like cinder block bricks.
Okay.
Yeah, yeah. Oh, it looks like a pretty standard building. Wood frames, wood doors. The roofs are different, right? Because of the heat. A
Hmm.
lot of times the roofs might sit off a couple feet from the top of the cinder blocks, right, to get some ventilation and flow through. A lot of like
AC?
tin roofs or aluminum. No, no, no AC. No AC. No power.
No power
The
at
power
all?
the power is generator power. And
Okay.
so that we go to Santa Clotilde is a small town.
Hmm.
They have a mayor's office, they have a school, they have a little police station. And that's probably the most built up town along this whole stretch of river that has those things. And they have a school, and that's kind of the main thing too, right? So they have like a primary school and they call them primary and secondary school. So, grade school and high school
Yeah.
equivalent. And that draws a lot of people to come live there because then their kids can go to school. And some nuns from Mexico actually run that, and they do a beautiful job. And interestingly, we're one of the few places we have a contract where the church and the state provide these services kind of jointly.
Okay.
So we have a convenio both for the school, which I'm not a part of, but I mean, in terms of my activities, but
Yeah.
but there's not a lot of places in Peru that have these agreements, so it's a little unique. But anyway, so the town, because of the school, has probably when school's in session 3,500 people, maybe 4,000.
Whole
The
town is
town, yeah,
comprised about that
yeah,
many. Is it and it's dense? Is it a dense area?
pretty dense. Yeah, I mean the houses are pretty close together, and it's kind of on three levels in terms of the river, and then you kind of have kind of built up on a hill, right? So you
Yes,
kind of have
they
the first level and then steps up, and so there's cement sidewalks, there's cement steps, but the houses are very rustic and simple. Some have, depending on what level they're at, right? The ones closer to the river are built on stilts because the river, amazing. It's amazing. It's hard to describe in words, but it raises and drops like 40 feet.
40 feet.
Yeah, because of the rainy season
Oh
and the
wow.
glacial melt. So like,
Well, that's gotta be beautiful when it's low to look in on everything and
yeah. And then you can walk on the shore, and then like several months later, that shore is
uh,
you know
how is it?
under
Is it
under
does it slowly bow out or is it like like cut in?
the center's pretty cut in, right? It's not necessarily deep, but it's wide and it moves, right? Like the current is powerful, and then the edges, it kind of will curve and cut its way in, right? So the river is the living thing; it changes,
Yeah.
and so actually, there's a little area of the lower part of town that's starting to actually get a crack in the middle of it, and it separates a little more. So over the
Does
next few decades, that part of the river in town is probably the river's going to eat it. So
is are the animals and that sort of thing like part of your daily life, or is it kind of like, hey, that's separate, just keep an eye out, or
yeah,
are you kind of like
it's kind
you're
of
in the jungle, like you
it's
gotta
not as
watch?
much as a jungle as like people listening and sitting there imagining are like because it's like a little town,
Yeah.
right? So it's urban. So if you take a hike and start hiking 2 miles outside of town, you're jungle and you got to worry about animals.
Hmm.
If you go to the outlying communities, so they get around with pretty much hollowed out canoes. They'll fell a tree and cut out the middle and then either row, with a paddle that they make, or they'll get a little outboard motor, like a 9 horsepower motor that they kind of put in the back and just drop it in the water and steer the boat. And so they call those pecky peckies. So, but those towns, they're a little more rustic. They're not using cinder block. They're usually using, dirt floors or raised on wood pillars. They kind of have wood, literally that's the abundance they have. They can cut down a tree, cut boards, and dry it out.
Yeah.
You know, make stuff, tables and furniture, but walls. And depending on the bark, I mean, they're so good with the trees and the plants. You know, they'll do medicinal treatments. They'll do salves. They'll use the sap of trees. You know, for wound care and so they use a lot of natural remedies. That's the first thing they do before they even come to see us. But that's a little bit like what it's like. You know, they're thatched roofs, right? They'll take the leaves and build a roof, and they usually build things like in community. So they'll call it like a minga, where somebody needs a new house, and they get the community leader together and say, okay, we'll put in this part in the work, and you guys put in this part, and so when they have all the supplies, then the whole town comes together and like puts a roof on a house over 2 days.
No kidding.
So that's kind of
That's
pretty
different.
common.
Yeah, that's kind of special. I mean, it's nice to have community for sure. And you're not firing me. No, I'll come fix your roof. I'll
Yeah.
bring my guys. We'll do what you need. But the so that's a very juxtaposed way to do medicine, right? I mean, you're
Yeah.
talking that's primitive, and it's the way they've been doing it for a long time. I want to ask you a double part question. Did you get any like hate, like pushback from the community? Like, hey, what you're doing is like we're against it because it's like from a modern place, and really what's important is like preserving these and our methods and our ways. And then also you find can you steal from them, like intellectually? Like, have you learned a lot? Like, those two seem so polarizing, but they also seem, obviously one's a derivative. Like, eventually we were from that. Eventually, somewhere in the line of history, we came from something like that, and that's kind of preserved. So it's almost like you get a look back in time, and obviously, like you said, like whatever works is still preserved because it's always worked and it's been around. How do you? I mean,
Yeah.
how do you meld those two? Do you meld them? Is it like, what do you do with that? That seems like you must have a very deep knowledge of medicine beyond most doctors because you've been in this setting, right? Or no? Is it separate?
I think I have a much deeper experience. As you've heard, I kind of like to do a lot of things or have interest in everything, right? So
Yeah.
to be medicine and pediatrics and do moonlighting in an ER and an emergency room, and then going to Peru and working remotely, and then coming back and actually training more in infectious diseases, which is what I do day to day now. So
Okay.
I'd say my broad swath of experience, it's not necessarily, I think it's experiential knowledge. So I would say, yeah, I think I have a lot more experiential knowledge, not necessarily book knowledge than everybody, but I can say, oh, I saw this, or this is how we could treat this without, what we typically think of. But getting back to your questions, I think because the priests were there before us, the priest doctors from
Mhm.
86, and then we get there in 2012,
Okay.
a lot of that may be resistance from the community. Probably they already had built the trust of the community. So I don't think we dealt with that a whole lot.
Right.
Like,
Otherwise, you wouldn't be there, right? If there was
yeah,
so much of it.
yeah. I think there was experience in like certain cases. A lot of times, like I said, their first step wasn't us. They've gone to their curanderos or their sacerdotes or whatever the medicos. They often called them medicos in the community, and so um, they often the treatments maybe failed. Right, like they tried that and it didn't work, and so
Well,
like now we're gonna go to the gringos.
those
So,
two,
so
the where did they go? The two terms you just used before medico. What are they, and like what do they kind of do?
yeah, so well, more so the curandero. That's kind of typical, and probably some of the other places I went to, Guatemala, they would call it. That would be the local healer, and usually the local healer um, would be acknowledged by the people as having a talent or a training or.
They're like botanists mainly.
A good question. Some of them have experience and know the plants very well. Some of them have been passed on traditionally, so maybe their parents taught them the rituals or ceremonies, or methods to treat things, right? And so they all have a big common spiritual. Um, we were talking earlier about the psychological and physical and how that affects your body, and I
Yeah.
think they actually use a lot more spiritual side of that too, or try to explain phenomenon related to their environment. They're so much more in tune to the cycles of the sun and the moon and the
Yeah.
temperature and the plants and this. And um, so I think the people that have that knowledge within their community, this is from my perspective, I don't know if this is 100% true, but
Mhm.
that have that knowledge, whether it be passed on or they were gifted with it or blessed with it or intuitive because they had that. And there's certain, and then so they actually use the term medico, which would be like doctor, to be somebody that could help them.
Mhm.
And some of them had certain um, skills, and then there's certain ones that had the skills. So they would call certain medicos, I don't know if I'm pronouncing it right because I've just been away for a while. It would almost translate to masseuse. So somebody that had joint pains or a broken arm,
Mhm.
they would go to this medico to get things,
Fixed.
fixed. Or if somebody had like the evil eye, right? Kind of that spiritual thing. And they don't necessarily call it that, but mal espiritu. They might have a ritual, and that's kind of I think the basis of the ayahuasca treatment too, the plant-based treatment that has some psychedelic properties, but there are some very good physical properties of that. And so some um, curanderos or medicos are trained in that. Actually, only the highest ones. It's not all of them. And so and they're recognized. Um, and so they each there's three or four different. Some are really good with the plants,
Mhm.
right? What teas do they make? Use the leaves and boil it, or what plants do you eat? Some people would get diagnosed with cancer. They call them vegetales, like vegetables, kind of, I guess but that would be plant based treatments of diseases. And
Were
some
they
people had an
effective? Like, did you find were you surprised? Like, wow, did you
I
see anything kind of?
Yeah, there were certain things. And so going to like, did we learn anything? Can we take anything from there? Because we were so busy, and unfortunately because we're so set in our ways,
Yeah.
and it takes time, and I think it takes a mentor, somebody that can teach you that. And it was hard for us to really have that. I wish and because of the way the system was set up before we got there, it would have been nice. We've talked about like maybe we have a medical work on our staff, right? Like with us. Like how does that look?
Yeah.
Like what would the people think? So like things we've always pondered and thought about but never put into practice. Um, but there was something called té de algodón, which is like cotton tea. So they
Okay.
take leaves of a cotton plant, which I think is a different type of cotton plant than what we have here, but still I think some kind of variety.
Mhm.
I'm not a botanist, but
Yeah.
this must have had some kind of chemical property that was similar to what our body produces called oxytocin,
Mhm.
or what we chemically make pitocin,
Yep.
to stimulate labor, right?
Yep. I know about
So
pitocin.
when women get like the midwives, or usually the older ladies
Mhm.
in the community, like there's a young lady in her first delivery, or she's really advanced and she hasn't started labor yet, they might go, oh, drink your té de algodón.
Or you got
And
an eager grandma that knows how to put it together.
yeah,
Come on.
that's usually who is preparing it,
You're,
is the mom or the grandmother. Yeah.
I'm
Of
only
the
6 months. You look 8. Come here.
But they would come in and did you drink? Oh yeah, we drank and then they'd be coming in labor, and like that was so like I'm sure if we had an organic chemist, they could go extract every chemical that came out of that tea, something that is pitocin or mimics it would be there, right? Like
No
it's
kidding.
to me from the science aspect, there's got to be tons of that.
Yeah.
There's tons of that. I mean, they had this sangre grado. There was a tree sap
Mhm.
that they would put on open wounds, right? They work with machetes. They live in the chakra. That's what they call their farm. So usually that wasn't right next to their house. They would walk in, they would clear a space of land, and they would typically plant yucca, so
Okay.
the root base, or cassava, yucca,
Mhm.
and plantains. That's like the staples. That's what they have all the time. But if they're out there working with their machete and they cut themselves, like they're out there, right? They don't have usually they're farther away from the river, so they can't wash it.
Right.
They'll wrap it in a towel, but what they'd use is this sap, and they'd just put it on there. And it must have locked it in or has antibiotic properties, because rarely did these wounds get infected when they were putting that on there. And
Interesting.
so there was stuff they used. Now there's cases, and I didn't personally see it. I think Jack and Mo did mention, like they had patients that had cancer. Like maybe a cervical cancer in a woman or something that appeared to be stage 4, stage 3.
Yeah.
And then, they would go in and maybe get treatment or decide, I'm not going to go get treated, or I don't agree with that treatment. Then they would go and get treated with the vegetales,
Yeah.
and then they'd come back. So there's reports of people coming, like the cancer's gone. So are these true? I don't know. Are they? I'm sure it's possible. It's just, to me, it's interesting. What was the vegetales they treated, and like, will this work for everybody, or is this like it happened a 1 in a million type of thing? I don't know, but there's definitely a lot of experiential knowledge that I think we just neglect because of ego or resources. But there's probably a lot to be learned from
From
those plants and from the people. And I'm sure, and I know, I'm sure the pharmaceutical companies are starting to work on this and have people down there. There's some labs trying to extract it, but
very interesting. It's so then you guys are dealing with more kind of like what type of medicine are you practicing? Because they're practicing, I don't want to call it holistic because I mean I don't know
yeah,
if I'm going to offend anybody. I don't think it is necessarily. So how do you guys fit into the mix over there? Like what
yeah,
when do people show up their medicine man? They're like he's wasted and I couldn't get what I needed.
yeah.
Is that real?
That's real too, right? Yeah, there's some people that are considered medicos, but yeah, unfortunately, there's quite a bit of drinking and alcoholism, with the poverty, lack of jobs, and actually they ferment their yuca. They call it a masato, so it's a fermented drink. Um, Traditionally, used to be, you chew the yucca to get the fermentation and spit it into the bowl and let it sit a couple days, and
Okay.
then you have your masato. But a lot of times now they'll use some sugar and ferment it chemically, um, but unfortunately there is quite a bit of drinking that happens. So yeah, yeah, there's been cases like that. I would say because they've built up. I mean, there was programs where um, like well child visits, we call them here, right? Where you take your kid to the doctor, they get their shots, you look at the growth rate. We do that there, right? So there's a general flow that comes to the hospital for preventative care. People who maybe had a loss of a delivery or were worried,
Mhm.
so they can come and get prenatal checks and ultrasounds, and care, vaccines, injuries. So a lot of times they would see somebody get cut with a machete. Not that they don't trust in the science, they'll use that. But if it's something big and they're bleeding everywhere,
Yeah.
So I'd say like a lot of the emergencies, right, or fevers, right. So there's malaria and dengue and stuff. So when they just feel terrible, they come. Um, so I think it's a lot of response to illness that we do. Um,
Is it wound? I would think
yeah.
it's like wounds. Like, do you do surgery there? Like, are you doing a lot of?
So I'll do a lot of wound debridements. I'll do a lot of what we said earlier, suturing, so sewing up
Yeah.
wounds. And then we're the only ones there, right? It's 6 hours away, so we did what we'd had to do. Now, if some people listening know the show MacGyver, do you know the show MacGyver? Do you
I know
remember that?
MacGyver.
Yeah, yeah. So I compare Jack and Mo to the MacGyvers of medicine. They had everything there, because they needed to use it at some point.
Yeah.
Right? Like they had this little kit for people that had like bloody noses in the back that are really hard to stop.
Okay.
Like they had this little kit of like what you would do. You had like a little sterile string. You'd put it on gauze. You'd kind of like, put it through the back of the nose and kind of pull it and tie it in
Like
the front so it
floss.
wouldn't fall. Yeah, like they had all these little things set up like chest tubes, but the old chest tubes, like where the tube would go in the chest, but then the tube would go into a glass bottle and then the next glass bottle to create a vacuum. That's what we
Yeah.
did in the 60s. So the first day I was there, I see this set up.
Yeah.
The lady had a big, fluid on her lung and they were
They were
draining
draining
it
it
that
like
way.
that.
And it's like, well, it works, right? Like we have these fancy kits and I don't know, we're so wasteful. We throw everything away, right? It's like plastic is a one-time use.
Yeah.
From one thing, it's good because then nobody's getting like an infection or HIV because it wasn't sterilized properly. But
Yeah.
I think we go a little too overboard on that regard in terms of how much we waste here in medicine. But they had everything, and they just initially, they were internal medicine doctors, right?
Yeah.
I think Mo was a family doctor and Jack was trained in internal medicine, so they weren't pediatricians, they weren't surgeons. But what happened when pregnant women started coming in and they needed C-sections, they weren't able to do it. So they would get on the boat, get the lady to Iquitos, and then ask the surgeons or the obstetrician, the OB-GYN doctors, can I go into surgery with you? And everything was smaller then, right? In terms of how many, the population, how many doctors were working. They said,
Hmm.
yeah, sure, come in. And so with every C-section that happened in Iquitos, they would help the surgeon do it and learn. And then I know Jack came back to the US and again, everything was easier. He just said, I'm going to spend 6 months with the surgeon. Surgeon said, yeah, come on. So he learned how to do appendix and C-section. So when they went back down, they could do them. And so they just, over 20 years, it wasn't that they just responded to the needs. So
Right.
whatever needed to get done, they just figured out, okay, I got to learn how to do this over time. And it wasn't over one day or next. And then they passed a lot of that knowledge on to us. Like I said, Tony knew how to do C-sections. She got trained here.
Hmm.
But we were able to do some C-sections and minor surgeries. And like they taught me how to do spinal anesthesia. So like I, I'm, I
Are you
did seven.
proficient?
I'm proficient. I'm proficient in like a spinal anesthesia. I'm proficient and I can handle a delivery as long as it's not coming. But I mean, I kind of joke, I said experiential. Like,
Yeah.
probably not going to meet many med peds doctors that have done 7 deliveries in a C-section,
Got you. I
right?
got you.
Like
Yeah.
when I came back home when I did primary care, it was
Mhm.
hilarious. I think about a month into work, there was a power outage at the clinic. Right, half the time I didn't work with power in Peru,
Yeah.
and everything here is like connected to all the orders are in the computer, and they're like, oh my, I think we're going to call all the afternoon patients and tell them to cancel and reschedule. I'm like, well, why? Like, I have an otoscope, I have paper, I have a pen. Like, don't cancel any of my patients.
Yeah.
Like, we act like the sky's falling, like we can't function without it. And so
Give them a discount for, for no power.
right, but it's just like how much we become dependent on stuff, and so it was kind of the neat thing, about being down there. It's like you just worked with what you had and you did the best you could. And
Well,
oftentimes it's nearly as good as what we have here. Not always. There's a ton of things that we're missing, but I mean, the quality, you can give good quality with low resources.
I was talking about something similar to this, but it's kind of like why like the relic and like the old ways are really important. Because if no matter how far you move past them, you never move past the possibility of collapse. So you should never give them up. And you need to preserve the relic just like you preserve the new age genius. Like you need that. And I feel like I like saying the word primitive and in a way of intelligence, right? Like you say, oh, it's like a bottle. It's like, can you believe they would do that? But if you did that way back in the day and you save somebody, you are like the height of medicine and you're a godsend. And Jesus is the answer if you're in Peru, because obviously these doctors are, also religious. Um, but yeah, no, I think that's really cool because in a lot of ways that you kind of are a relic or have that built into you where without that, without empirically going through that, you don't, you just aren't that person. Like you don't have the experience um, of those things. And hopefully that's never the case, right? Hopefully you
Right.
never have to stab someone in the ribs and train their, and do that for them. Um, and even if it's a possibility, that's very different than actually seeing it or being a part of it. That's really cool. So, you, you,
So I'll happily take the description of a relic. I think Jack and Mo were the original relics, right? And like you said, right? Like that was the top notch treatment 30 years ago, 100 years ago. Like that was the interesting thing about medicine to me is I didn't realize this until Peru. Just thinking of that similar how we've evolved and advanced. There's all these things that are named after old physicians. Whether
okay.
these physicians are from centuries ago, like Virchow's triad, which could be like, people have blood clots because they have inflammation and damage, and like there's certain things that fit clinically to a disease. And I always thought, man, these people are the most brilliant people that recognized, like, just, I don't even know what to say, but like lupus, right? Like, like you have this, and this, like, and they didn't have the fancy lab work. But down in Peru, I realized, like, okay, we're starting to see patterns. And you have to physically see the exam or the clinical picture, right?
Mm,
Like a dengue outbreak or leptospira, which are infectious outbreaks.
mm,
Like initially, I would say, well, how did people realize this was lepto? Maybe they didn't know it was lepto at the beginning because they didn't have a test to test for it. But all of a sudden, you see people coming from the same area of town in the same community, the same barrio,
mm.
that have fever and headache and backache.
Are you
And
seeing
it's
the
like, oh, and then this and that, and then it's like, okay, these fit dengue fever. Let's test for dengue fever. And I just remember in medical school always thinking these old time physicians that things are named after of how brilliant they were. Not that they weren't, they are brilliant.
right?
But now sitting there, they would just sit there and see the patterns I'm seeing, right? Like I have the information already thinking, okay, we can test for dengue. They didn't have that, but they said, okay, I'm seeing this pattern. What is it? Or these things all line up together and they respond to this treatment. So it was kind of cool seeing that because you don't see that here.
Well, pattern recognition
Yeah.
is a huge, I think, part of survival and awareness, right? Being aware in general is noticing things outside of yourself. You could be self aware and self reflective, things like that, but being aware of your environment is usually what's going to help you survive. But fundamentally, it's very important. And I think it's a part of like high intelligence, like being able to see patterns, abstract. And it's, intelligence and knowledge can be very like visual, right? Like you have the
Yeah.
diagnosis even if you don't have the words because you recognize the pattern. And I feel like too probably like when I think about medicine from a long time ago, which I know nothing about, but when I think about people and I think about like doctors, they come to you, right? Like in a lot of ways, a hospital, these aren't my words. I am paraphrasing from I'll say Alan Watts, like doctors, hospitals are for the convenience of the physician because like historically, the physician was someone with, proclivities or maybe it was something that they learned, but they had an innate sense within them. And, like really good doctors, they probably like they look you over and they can smell certain things, certain chemistries, and right away they can start to diagnose and see visually, okay, I'm noticing this pattern and now I can make the right diagnosis and be accurate, hopefully, hopefully that's the case. But I think it's interesting and I like looking back because a lot of what obviously what we have now comes from what has happened previously. And I think a lot of history and knowing like the history of medicine and where things come and like the idea of like a relic or not leaving things just to be buried and forgotten really help inform the present, and they help people that are really, I want to say, like are in more so your situation because now you're aware of this pattern and you see the derivative. It's like, oh, it gives you that aha, like you say, like that aha, you see that pattern. And then it's got to be kind of like gratifying because you got to feel like I'm where I'm supposed to be in a lot of ways. Like, without getting too like off the topic, you have like synchronicity and things like that. People put a lot of emphasis on that, whether they should or they shouldn't, but everything is kind of relative in life. And I'm not saying you should go and change your life because of a coincidence, right? But noticing patterns that seem to frequently propagate probably have a lot to do with what you're interested in, what's on your horizon, who you've been studying, the vocabulary you've been thinking about, and it affects like your whole environment, right? Like in a very subtle way. And having an attunement to those subtleties to me is kind of what life is about. I hope I can achieve a place where I have attunement to subtleties. I don't know why. And I feel like as a doctor, all you're expressing is these attunements to subtleties that you have to be to be to be good, I think, if for lack of a better word. So I think that's very interesting. And what have you what have you seen like coming in? What do you see down there mostly? Is it rashes?
Common things are common. We say that in medicine. So I think a lot of it is like colds, respiratory infections. Unfortunately, due to the hygienic conditions, a lot of it's like GI stuff, diarrhea, parasites, and then the tropical stuff, right? Malaria, dengue, lepto, leishmaniasis, stuff that's in that they're exposed to, right? You're not going to get that in Chicago just because there's not the vector, there's not the climate to
Yeah.
be to expose to those risk factors. Trauma, so machete wounds, you know, they use little motorcycles or moto taxis. They can, fall off of those and have injuries. And then the regular stuff, pneumonias, and unfortunately, because of those stilted houses, they'll fall. Unfortunately, so we'll have some paraplegics. Then they develop wounds or have the complications that come from that. Um, there's a lot of high blood pressure, not as much diabetes, although that's trending up. But you can imagine their lifestyle. They go to the chakra, so they're walking a couple miles. They're out in the heat. They're using their machete. Like they're pretty fit. You get these their life expectancy. It'd be interesting to see what the real life expectancy is there. I don't see a lot of 80-year-olds there, right? Like, 50s, 60s, some 70-year-olds.
Yeah.
There are 80s, and there's actually somebody we know that just turned, I think, 90 last week that we know from down there. But it's not like here, right? Like,
Most
a
people
lot
in
of
it.
my patients are in their 70s or 80s,
Yeah.
and I don't see that many down there. So, but I don't see a lot of heart attacks either. I don't see a lot of obesity. But as the transport upriver,
Yeah.
it used to be they didn't have those faster boats. They would have what they would call lanchas, which are just like big, slow moving, almost like, I don't want to call them tugboats, but like people would set up their hammock
Hmm.
and they would get supplies for the month. That's what the priest had one of these. They called the barcaza. They would go down and get, tons of bags of rice and potatoes and the hammock, it'd take, 2 days to go down and 3 days to go up because you're going against current. And that would go once a month, right? You get your supplies once a month. And so with that, and with the development of towers and internet, right? So now there's cell phones there, Starlinks, and then there's internet, which is helpful for us because we're so connected.
Yeah.
Like,
Oh, you get a piece of home.
yeah. And so, but with that comes kind of processed food.
Is that the
And
diabetes? Because that seems crazy. Why would they have I feel like that's just
yeah,
American, even
well,
though
it's
obviously.
worse here, but I'm saying like here, the people who have wealth, usually, I mean, this is again generalization,
Yep.
right? Have extra time so they can go to the gym. They have the money to pay for a gym. They could do it at home. They have the money to buy organic food and eat healthy. So here, the wealthier people tend to be healthier, this as a generalization, not the rule.
Yeah.
And in Peru, the people who have more money are able to buy more of food, but the food they tend to start buying, it's not as, I think, bad as here, but processed sugars. So our diabetics are professionals, the teachers, the police officers, the people that have a full-time job tend to
That's
be in poorer health down there,
interesting. That's
right?
yeah.
So, but yeah, so we're seeing as cultures change where, now they can, anywhere in town, you can go get a Coke or a Pepsi or an Inca Cola.
Yeah.
You can get bags of chips. You can get, they didn't have that in '86 when Mo and Jack got there,
Right now.
right? So there's just a change. You'd call it advancement, but but now there's boats that come down every day. They can load up in a Ketos and bring it up every single day
What?
if you wanted. So, so things change that way. But
So okay. Um, you have 10 more minutes.
yeah, I could do 10. Yeah. And sorry,
Yeah.
running out of time. This has been
I
fun. I could go for a long
know.
time, but
Maybe we should get into it a different time. But I wanted to talk with you about the infectious disease part coming back here and being involved with the infectious disease.
yeah.
How long have you been doing infectious disease?
So I started my standard formal infectious disease training. Well, timing's everything. I'm just trying to think back here. I was doing primary care, and to be honest, I thought it would be different. I saw a lot of high blood pressure, a lot of diabetes, a lot of anxiety, a lot of depression, a lot of people who want, didn't know how, didn't want to take care of themselves. And I'm like, I don't know if I can do this for 30 more years,
Yeah.
right? I had always, like you said, internal medicine is kind of everything.
Mm-hmm.
So part of internal medicine is always infectious. So I always intellectually had a curiosity. I really enjoyed infections and antibiotics and how to treat it. And then going to Peru, like we saw all this whole new book of tropical diseases. And then I did a tropical medicine course specifically for, infectious tropical diseases. That was a 9-week course in Lima and other parts of Peru. It was just, and had, again, teachers, mentors that are still friends and mentors to this day who are amazing physicians, both clinically. And so when I came back, I'm like, what do I enjoy doing the most? Who influenced me the most? Like and infectious disease, right? I came back, I had a ton of knowledge on HIV, and I wanted to treat HIV patients. And they're like, oh, but you're primary care. You didn't get ID training, so you can't work at the HIV clinic.
So you need.
I want to work at the travel clinic because I had travel, experience, and that was part of the course I took, is to do travel medicine. So people going get their malaria prophylaxis or their altitude sickness. We talk about the risks of traveling. I enjoy that too because I like traveling and just having those conversations. Oh, you can't do that because you're not ID, you're primary care.
Yeah.
And so I was kind of, a little blocked out by the system, and that's not the same everywhere in the U.S. But so I was like, you know what? I enjoy that. I like doing that. The things I want to do, I can't do because I'm like, screw it. I'm going to go back and do ID training. So, and I'm happy I did it. I really enjoy this kind of focus I have with my professional career. But it was 2019. So I applied. I started in, let's see, the academic year is usually like June to the following, June till May. So I started June 1st.
Yeah. 2019.
2019.
And then
I'm on my way, doing my training, HIV care, typical stuff. And then we hear in December, end of December, I remember those first like New England Journal articles talking about this novel virus.
Yeah.
And,
don't let anyone cough on you. I remember early.
The theory, right? Like the theory, like, oh, this could spread. Man, it's looking back, I feel so naive. Like, oh, it's fine. It's there. It's going to go around a little bit because we had bird flu, right? And we had avian flu.
Yeah,
and
West Niles.
And stuff came to the U.S. and you had a couple hundred cases. So I was like, that's what it's going to be. Oh, man. And that changed everything, right? Because my training was a 2-year program, and 14 months of it was COVID. Really, right? So, I mean, part of me feels a little gypped. Like I didn't get my full
got thrown to the wolves. So
yeah. So COVID hit, and my training and life was completely different, right?
So you started. So you got your training. You came here 2019, or you started doing ID in 2019, and then COVID hit.
Yeah.
So because I know you have to leave, let's do it again. I'll have you come back, and I'd like to talk about that in like some detail if we can, like the whole COVID thing, because there's other things I want to get into about it that I think we're going to cover in the next.
I think that would be more complete if we had a whole different discussion. So
cool.
Yeah, this was fun.
Yeah. All right, I'm going to wrap it up here. Glad to have you on, Brian.
All right, thanks, Sean.
Thank you, everyone, for watching. See you soon.